Today we're going to talk about three topics. We're going to talk about the vascular injury, Cauda equina syndrome, and necrotizing soft tissue infections. I'd like by the end of the talk for you to be able to describe the signs and management of vascular injuries in patients with a traumatized extremity, to describe the signs and symptoms of Cauda equina syndrome, and to describe the role and limitations of the history, exam, and laboratory findings, as well as imaging findings in patients with suspected necrotizing soft tissue infections. Please feel free to enter questions or comments in the chat, and Dr. Lang and Dr. Pilson will stop us and we can answer those as we go along. Vascular injuries are generally associated with higher energy extremity trauma, and that can be blunt or penetrating trauma. And certain low energy injury patterns can also lead to vascular injury, and the most common one that we think about are knee dislocations in obese patients, which have an unusually high rate of vascular injury associated with these relatively low energy injuries. It's really important that orthopedic surgeons be able to identify and manage vascular injuries associated with extremity trauma because they may evolve over time. They can cause critical limb ischemia that can lead to amputation. And for many injury patterns, they actually increase the morbidity and decrease or worsen the outcomes, even when limb salvage can be performed. The incidence of vascular injuries in extremity trauma depends on the type of injury. And so it's only about 1% with closed diaphyseal fractures, but it can be up to 16% with knee dislocations. And so it's important to have a high suspicion or high index of suspicion for these injuries, especially with things like open fractures, segmental injuries, knee dislocations, and floating joints, or fractures where you have injuries where you have a fracture both proximal and distal to a joint. It's important to understand what makes vessels susceptible to injury. And for penetrating injuries, it could be direct trauma with like a laceration from a weapon such as a knife, or it could be indirect, like with a gunshot wound, which is where you have soft tissue expansion or soft tissue displacement, and that this can cause a vascular injury, even if it's not a direct laceration. So this figure here shows a direct injury to the popliteal artery following a gunshot wound. And if you look closely, you can see an area where there's some obvious injury to the vessel, as well as some thrombosis in the vessel proximal and distal to the injury itself. For blunt injuries, direct combat or vascular injury could be from direct contact with the injured bone, like from a laceration from a fracture edge, or it could be an indirect injury, which might be from impact from the fractured bones or from a stretch injury. And so in the diagrams on the right, you can see an example of an indirect injury where the patient had knee dislocation, either anteriorly or posteriorly, and there was an indirect injury to the popliteal artery after the knee dislocation. And you can see that in the image on the left, when you have a posterior dislocation, there tends to be more of a transection as the tibia, the posterior aspect of the tibial plateau kind of abuts that fracture or the vessel itself. Whereas when you have an anterior dislocation where the proximal tibia is displaced anteriorly, then you're more likely to have a stretch injury where the because of the close proximity between the popliteal vessel and the adductor hiatus, it's very closely tethered there. And so when the tibia pulls anteriorly, then you may have a stretch injury that can cause an intimal tear, for example, as opposed to a direct transection. When vessels are tethered anatomically in a very specific location, then it makes them particularly susceptible to a stretch injury or a traction injury. And the most common place that we think about this is about the knee. And think about the anatomy that you learned earlier in medical school, and you'll recall that in the adductor hiatus, the popliteal or the superficial femoral artery becomes the popliteal artery as it passes under the adductor insertion on the medial epicondyle. And so in that area where they're very closely tethered, then they're particularly susceptible to these closed or indirect traction injuries. And as you can see in the injury on the left, the drawing, there's lots of other soft tissue structures like the hamstring origin insertion, as well as the gastroc fascia that are also tethering the popliteal artery in that area. And this makes the vessel particularly prone to a traction injury here. Additionally, it's important to understand that the degree to which tissue perfusion is interrupted depends a lot on the presence or the absence of collateral flow. And Again, we think about the knee as being an area where there's relatively limited collateral circulation. And primarily, those are the geniculate arteries, which you can see on the diagram on the left, as well as the angiogram on the right. And so, proximal and distal to the knee, then there's a plethora of collateral circulation, not so directly around the knee itself. And so, when you have an injury to the popliteal artery in this location, then it's very easy to get relative ischemia distally because there's not good collateral flow. In contrast, in the lower leg, then the collateral circulation is more robust. And so this is why you may see in patients that have a tibia fracture, for example, then distal perfusion may be preserved despite having an injury to one or even two of the vessels in the lower leg. And the foot may be perfused through the third vessel. So it's important for us to recognize that a patient has at least one vessel flow to the foot, but often you can have adequate perfusion even if two of the other vessels are damaged. So I want you guys to think about the diagram on the left, which is a reconstruction of a CT, and try to correlate that with both the anatomy that you recall as well as with the angiogram on the right that shows the what we call three vessel runoff from the popliteal artery through the tibioperitoneal trunk, which then becomes the peroneal artery and the posterior tibial artery, and the anterior tibial artery into the lower leg. I want to spend some time discussing the evaluation and management of a patient with suspected vascular injury, because this is primarily what you'll be doing when you're evaluating patients in the trauma bay or after they've had some kind of extremity trauma. So, recall that the first step of evaluation of any trauma patient is ATLS. And it's important, that we like to focus on the orthopedic exam, but we have to remember that all interactions should start with ATLS. And so when you get to the C, ABC, then think about circulation. And in our situation, that can often be hemorrhage control. Patients with a bleeding wound may have a bone or a soft tissue injury, or they may have a peripheral vascular injury. And so consider intervening with something like a compression dressing or a tourniquet, which can be used to stop hemorrhage and may save the patient's life. The next step in evaluating patients with extremity trauma and a postular vascular injury is to perform a physical exam. And we really emphasize the pulse exam when we're doing this. Signs of vascular injury were traditionally divided into what we call hard signs and soft signs. And so you may hear that terminology still used. If you look at this chart, then hard signs are listed on the left side. And those are things like pulselessness, pallor, paresthesia, pain, paralysis, having a rapidly expanding hematoma, massive bleeding, or an audible bruit. And I feel like we hear a lot of our general surgery colleagues talking about these hard signs. And the idea is that the hard signs are definitive signs of a vascular injury. It makes sense, of course, that having paresthesia or pain or paralysis could also be from something like a neurologic injury as well. So I think there's definitely some equipoise with considering these as hard signs or strict signs of vascular trauma. But these should all really raise the red flag and make you very suspicious that the patient has a major peripheral vascular injury. In contrast, we also talk about soft signs. And these are things that like a history of bleeding in transit, so you may get that from the EMS team, having a proximity-related injury. So for example, if you identify that the patient has a peroneal nerve injury, or a sciatic nerve injury, then you right at the level of the knee or just proximal to the knee, they may also have a vascular injury. Finding a neurologic finding with a nerve adjacent to a named artery, like we discussed, and also a hematoma over a named artery. So those should all be, again, kind of signs that you should strongly consider that there may be a vascular injury. And it sounds really obvious, but I want you guys to remember that if there's a tourniquet that's elevated, then it's going to prevent you from doing a pulse exam, and it may delay the diagnosis of a vascular injury. So in this situation, step back and look at the patient, and you may want to remove the tourniquet as long as you're in a safe place where there's the appropriate interventionalist, whether it be a surgeon or an ED physician, someone who's there to take care of the patient if they truly do have a major vascular injury when the tourniquet comes down. Let's talk a little bit more specifically about the pulse exam. So it's important that we document the pulse exam in all extremities, and that includes the injured and the uninjured extremities. So I want you guys to stop and think for a sec. What if you're evaluating a patient in the trauma bay and you identify that the patient has asymmetric peripheral pulses? It's different in the right leg and the left leg, or the left leg is a normal pulse and you can't find a pulse in the right leg. What are some things that you guys are going to do to evaluate for that? And these are things that you can kind of put in the chat or just think about. Here's the list that I would encourage you to consider. The first one, again, is to check and remove a tourniquet if present. And again, making sure that this is a kind of a safe place to do so, where you have access to dressings or to a new tourniquet to put up if the patient does start to hemorrhage. Second, reduce the fracture or dislocation. You'd be surprised how much simple traction or stabilization of an injured limb can do to restore a kinked or a spasmed vessel. So again, you may see that flow returns once you have reduced the fracture. The third thing is to check the patient's blood pressure and also their temperature. Patients who are in extremis, especially if they've lost a lot of blood, may be very cold, or they may have pretty significant hypotension. And if that's the case, they may not have asymmetric pulses, but they may have pulses that are very difficult to feel. And so that's certainly something to consider. And the last thing is to check the ABI or the API. And so we'll go ahead and check about that and talk about that a little bit next.
Dr. Pierre, there is a question in the Q&A box that is from Samar. It says that it was mentioned that lower extremity vascular injury typically portends better prognosis due to increased collateral flow. How much does having comorbid diabetes or peripheral artery disease affect management in an acute setting?
That's a great question. So what I would say is that a patient who has comorbid diabetes or peripheral vascular disease, something that's already limiting flow to their extremity, is probably at higher risk from a much smaller insult. So it may be that something like a spasm vessel or decreased blood pressure, something like that is going to cause them to lose or limit, or is going to limit perfusion to their limb before it would in somebody who's young, healthy, and has no atherosclerosis. And so I would say that those patients are probably at higher risk for having an ischemic limb or at least inadequate perfusion with a relatively smaller traumatic insult to limb. Now, the other thing to consider is that when we talked about how there's collateral flow in the three vessel flow to the foot in the lower leg. They may have underlying peripheral vascular disease to the extent that they actually are not getting three vessel flow through the lower extremity, or through the lower leg. And so in that situation, they may already be one vessel down, so to speak, to the point where an injury to another vessel, just one other vessel instead of two, puts them kind of at that critical point of only having flow through one vessel to their foot. So, again, in patients in whom you suspect that, then I would say these are patients that you'll need to keep monitoring and make sure that you're repeating your physical exam, because we know vascular injuries can evolve over time, and make sure that that you're monitoring them very closely, because they may need earlier or different intervention than your otherwise healthy patient who can sustain an injury and rebound from it a little bit better. That is a great point. And I think probably for children, I suspect that the trauma surgeons generally are not called to see them because they're often low energy injuries. But so you guys may be the first and only patients to really do a vascular examination on those patients. And often, as Dr. Lang said, you need to be not only the person who's identifying those injuries, but the person who's really advocating for the patient that, yes, this is an orthopedic urgency or emergency. The patient needs evaluation and help drive the workup and also the management of that. So we'll talk about how, what that flow looks like. And you'll see that it's not, this is part of the surgery as a team, or especially trauma surgery as a team sport. You have to involve your other colleagues, but understanding this is very important so that you guys can be driving this workup and management. Let's talk about the arterial pressure index, or what we'll also learn, the ankle brachial index, API or ABI. And this is a really important skill for you guys to have as orthopedic residents and surgeons. The arterial pressure index is a ratio of the blood pressure in the injured limb and compared to the uninjured side. So you'll often hear it called an ABI, or the ankle brachial index, which is a systolic pressure in an injured lower extremity compared to the blood systolic pressure in an uninjured upper extremity. So again, you're comparing the injured extremity to the uninjured extremity, and ABI just implies that you're comparing it to lower versus upper as well. So we're going to talk about how to actually measure this. And this is a skill that you guys should all have. And I would encourage you to check out this video done by Stanford Medicine. It's like a 6 or 7 minute video, but it shows you how to do it. And so that, again, this is a skill that you guys can have in the ER. It's important that you know where to get a manual blood pressure cuff and Doppler ultrasound as well, so that you can actually perform this. So step one is to place again, we're going to find the blood pressure on the uninjured arm first. So we're placing a blood pressure cuff on the uninjured arm, and then a Doppler probe over the brachial artery. And so the idea is that then you can hear that. And so as you elevate the blood pressure cuff until you no longer hear a signal, so you're listening as you're elevating the cuff, and then you gradually decrease the pressure and watching the actual dial on the blood pressure cuff until you hear the signal again. So once you hear the signal again, then that's the systolic blood pressure in the upper extremity, and that becomes the denominator for the ABI. And then you simply repeat this process for the leg or the injured extremity. So you're putting the blood pressure cuff below the actual injury, so the fracture or the knee dislocation. Again, this isn't going to work for ankle fractures, obviously, because you don't want to put it proximal to it necessarily, but you're going to place a Doppler probe on either the posterior tibial or the dorsalis pedis artery. And importantly, you're going to use the higher number. So if you were to measure both of them, or if you don't have one of them, then you just use the higher number. Again, assuming that as long as the patient's getting getting perfusion through one of those vessels, and they should be perfusing the foot. So again, you're going to elevate the blood pressure cuff till you no longer hear a signal, gradually release the pressure until you hear the signal again. And then at that number, that's a systolic blood pressure in the lower extremity or the injured extremity, and that's the numerator for the ABI. And so once you do that, then you have the blood pressure in the the injured over the uninjured extremity, and that normally is greater than 0.9. And so again, here's the link for the video in case you guys want to download this and watch this video. So an ABI of greater than 0.9, greater or equal to 0.9 is 0. So if you have an ABI less than 0.9, then that's where they need further workup, because that suggests that there may be an abnormality in their lower extremity perfusion. And so depending on the institution, what could this workup be? Well, that could be a CT angiogram, or it could be angiography in a vascular suite or an interventional suite or in the OR. In my experience, a CT angiogram tends to be the preferred choice at most major trauma centers because it's quick, non-invasive, and there are CT scanners in most ERs or in close proximity to the ER. So that's probably what you'll see the most, but understand that historically the gold standard was actually arteriography or angiography. So this algorithm, which is taken from this Halverson paper, which is in the Yellow Journal, or the Journal of the American Academy of Orthopaedic Surgeons, really sums up kind of the evaluation and management of patients with extremity trauma and a suspected vascular injury. And I want you to note that patients who have a normal physical exam can be managed conservatively with observation without additional imaging. And so that's what you see over on the left, is that normal physical exam can be managed with observation. And remember that patients with vascular injuries can have evolution of their exam. So that may change over time, especially if they have an injury other than a transection. So if they develop a thrombosis or an intimal tear that can then become a clot. So monitoring for a change in examination is critically important, because if they have a change in exam, then that's when you're going to need to institute the next step of the protocol. Okay. So again, change in exam leads to it leads to kind of additional monitoring, additional evaluation. So patients who have either a change in physical exam or soft signs of vascular injury, then we'll go on and we'll measure the ABIs. Okay, so suspicion for vascular injury, change in exam, they're going to measure the ABI. If it is greater than 0.9, and that's where we're going to go on to this kind of next section, then that's where we start to see that ABI greater than 0.9 or change in physical exam is going to trigger additional imaging. So that could be like a CT angiography or intraoperative or angiography in the vascular suite. Okay, so that's where they need additional workup. So ABI 0.9 needs additional workup. Patients with where they have an abnormal additional imaging. So if they have an abnormal CT or CT angio, or if they have an abnormal angiography, that's really what triggers surgery. And kind of historically, you'll hear a lot of our general surgery colleagues say, well, if they have hard signs of vascular injury, that triggers surgery as well. And I would say, in my experience, that's really limited to patients who have penetrating trauma. So you get stabbed in the medial thigh, you have a giant hematoma there, and pulsatile bleeding, yes, they may go straight to the OR. But for patients who have blunt trauma, then it's often prudent to, even if they do have some hard signs of vascular injury, get additional imaging studies to better localize it before going to the OR.
Sarah, one question we had in the chat box was, when you say that this is a potentially dynamic situation, what are your guidelines for how often should we be monitoring the pulses in the vascular exam?
Yeah, that's a great question. And I think that probably depends a lot. Your hospital may have some protocols and say every 4 hours or this or that. I'd say it probably depends on the clinical situation and what your suspicion is for underlying vascular injury. So for example, if a patient comes in with a knee dislocation, or they come in with a perineal nerve injury, so something that's in very close proximity to the vessels, and you have a high suspicion that they may develop or have a vascular injury, then that's someone I would monitor closely. And I might check on them a couple times in the first few hours after their trauma, check their pulse exam, and then if there's any irregularity, go ahead and check ABIs. And then again, if your ABI is less than 0.9, which is suggestive of having an underlying vascular injury, that's when you'd go on and get additional imaging studies. So in patients who you have a high suspicion or who have these injuries that are highly associated with vascular injuries, those are the folks I would check really quickly or check more frequently. If you have a long bone fracture and it seems like an isolated closed injury, then maybe it's okay. And they're not having any complaints. They have normal symmetric pulses. Their foot appears well perfused and they have a normal neurologic exam. That's someone it'd probably be okay to wait a couple hours to check again. And those can be tough to identify. And I think that's where kind of a keen physical exam can really help you, and particularly reevaluation. Because as Dr. Lang said, those don't always appear right away. And those if they had a normal CT, in some institutions, patients when they get their trauma CTs, they'll actually get a CT angiogram. It may be normal when they hit the door, and it may not be for another hour or 2 hours or 8 hours that you start to see clinical signs and symptoms that are suspicious for an evolving process. So let's just move ahead and talk about surgical management. And I want you guys to kind of understand that the goal of surgical management for these patients is to minimize ischemia time and to expeditiously restore perfusion to the limb. And this takes a team. And I don't know if you guys have seen this goofy meme recently from the Cannes Film Festival. But the idea is that this takes a team, and it has to include the ED doctors who are seeing them first, vascular surgery, general or trauma surgery, and ortho as well. And so we have to be able to work with our colleagues. And again, sometimes we're the people who are primarily evaluating these patients' extremity injuries, and we really need to advocate for them as well. So in terms of surgical management, there's two things that are really important. Revascularization, obviously, which is performed by our vascular colleagues, or in some institutions, the general surgeons, but also stabilization of the limb. And the idea is that for a vascular repair to be successful, then there needs to be a stable limb for it to be performed. So it doesn't make sense to repair a popliteal vessel in a knee that's dislocated, complete ligamentous laxity and is flopping all over the place. So what has to happen is communication between the orthopedic surgeons and the vascular surgeons to identify how are we going to stabilize this limb, so the vascular surgeons have a platform that then they can do the vessel repair or reconstruction. And so from an orthopedic standpoint, this usually takes the form of external fixation because it's quick to apply, it can cross joints like the knee, and it limits the soft tissue dissection, so the vascular surgeons can kind of do what they need to do. In some cases, particularly in upper extremity injuries, then limited internal fixation may be equally appropriate. And that's really a judgment call for the orthopedic surgeon. There's not really any consensus in the literature about which should be performed first, the bony stabilization or the revascularization. And in practice, a lot of times they can be performed simultaneously. For example, the vascular surgeon can be harvesting a vein graft while the orthopedic surgeon puts on an X-fix. So it really just takes good communication between the teams. There's several surgical management techniques to be familiar with. And again, these are primarily going to be performed by vascular surgeons, but it's important to understand what they're doing. The first technique you may hear of is shunting. And this is a temporary technique. And it's often where you're using a plastic tubing or catheter to essentially bridge the gap between the proximal and distal aspects of an injured vessel and to provide early reperfusion. So it's usually considered when ischemia time is particularly long or when it's already been prolonged and there may still be a delay to definitive revascularization. So it's a temporary procedure, but it does buy the surgeon some time. The second technique is primary end-to-end repair of an artery. And I will say that this really has a limited role because the ends of an injured vessel often have to be resected so that you're attaching just healthy vessel to healthy vessel. And that effectively shortens the vessel. And so it's primarily employed when there's a very narrow zone of injury so that you can still get a tension-free repair. And unfortunately, that's just often not possible. And so unless there is truly a very, very narrow zone of injury. And so what we more commonly see is arterial reconstruction. And when you have reconstruction, which is considered the gold standard for peripheral vascular injury, then you're using a graft, which is usually an autograft, usually in the patient's own vein graft, and you're using that to repair the artery. And often the vein graft can be harvested from the patient's uninjured extremity and often a lower extremity. So you may hear that a reverse saphenous vein graft is probably primarily what's used. And the vascular surgeons may be able to harvest that while the external fixator, for example, is being performed. And so here in this picture, those little arrows point to the anastomoses, and this central structure here is actually a patient's vein. You can see where some of the vein branches have been clipped off that was used to reconstruct the patient's injured artery. And then finally, in some institutions, there may be a role for endovascular repair for something like an intimal tear or some kind of luminal injury. And I will say that this is very institution specific because it tends to be performed by vascular surgery specialists or interventionalists, but it does require special equipment and angiography suites, which may or may not be available or appropriate to use in a patient who has acute loss of limb perfusion. So I want you guys to be able to recognize this and see what a shunt, an endovascular shunt looks like, or stent looks like on an X-ray, but something that you will not frequently see performed. And then the last thing that we really need to recognize is that patients who have a vascular repair or reconstruction are at risk for reperfusion injury. And this most commonly occurs when ischemia time is prolonged. And so surgeons should always consider doing fasciotomies to help reduce the consequences of this type of reperfusion injury. And in different institutions that may be performed by vascular surgery, general surgery, or orthopedics. But this is something where sometimes in my experience, the vascular surgeons may or may not think about this. And it's really because the consequences of a missed reperfusion injury are essentially going to be managed by orthopedics. It's really up to us to identify patients at high risk of a reperfusion injury and to advocate for early fasciotomies. And amongst individuals with lower extremity trauma, studies show that patients who have fasciotomy performed within 8 hours of a vascular repair have significantly better outcomes in terms of avoiding amputation and avoiding infection. So again, be an advocate for your patient, and it's worth having the conversation with the orthopedic team and the vascular team in this subset of patients. Cauda equina syndrome is another surgical emergency, and what it is compression of some or all of the lumbar and sacral nerve roots that results in a syndrome characterized by pain, motor and sensory dysfunction, saddle anesthesia, and bowel and bladder dysfunction. And although patients' primary complaint or what they first come in with may be pain or is probably most commonly pain, many people argue that without have some level of bladder or bowel dysfunction, it's not strictly Cauda equina. So that's always something that you need to really look out for. So going back to Cauda equina syndrome, this is one of those Latin things that you probably learned about in medical school, but the term Cauda equina means horse's tail, and it refers to these nerve roots, the lumbosacral nerve roots that extend from the distal end of the spinal cord. And so here you can see that on the diagram. And these nerves contains axons that innervate the legs, the bladder, the anus, and the perineum, as well as the posterior thigh. So in this illustration, it shows a large disc herniation at L3, L4 that's causing a mass effect on the Cauda equina, and that essentially is what is kind of causes, or really is the defining pathoanatomy of Cauda equina syndrome. So this mass effect on the lumbar and sacral nerve roots is what gives patients the kind of symptomatology that they have. Nearly half of cases of cauda equina are from herniated lumbar discs, but don't forget that only 1 to 6% of herniated discs result in cauda equina syndrome, and that's actually 1 to 6% of herniated discs that are treated operatively. And think about all of the disc herniations that we see that are not treated operatively. So 1 to 6% of herniated discs treated operatively are associated with cauda equina syndrome. And that really depends on the location of the disc herniation, its size, and any kind of underlying stenosis of the canal. So the rest of those disc herniations might be causing pain or motor or sensory symptoms, but they're not causing significant compression of the lumbar and sacral nerve roots to cause the saddle anesthesia or the bowel or bladder syndromes that are really characteristic of cauda equina syndrome itself. So important to remember that although it's usually a large disc herniation that causes cauda equina, it's actually really it's just like with peripheral vascular disease, any condition that decreases the baseline cross-sectional area of the spinal canal, which is most commonly underlying arthritis, that means that in a smaller disc herniation can actually have a similar effect. So again, if the cross-sectional dimension of the spinal canal is decreased for any reason, it's not going to take as big of a disc herniation to cause similar symptoms. An epidural abscess, as seen here on the right, can also cause a similar mass effect, as can an epidural hematoma. And this could be from a patient who is on anticoagulation. It could be a hematoma after spinal instrumentation or after a fracture. So all of those things could cause a compressive hematoma. It could be a tumor, an epidural cyst, a lumbar spine fracture, often a burst fracture like seen here that may be associated with retropulsion, or it could be iatrogenic, and this could be use of gel foam during surgery, placement of an epidural fat graft following a dural tear. It could be from surgery itself, or it could also be from chiropractic manipulation. So cauda equina evaluation, first think about the history. And I'd encourage you to really, when you're evaluating patients, often in the ER or in the clinic who you're concerned may have cauda equina syndrome, understand that these symptoms are not always acute. Sometimes they can have insidious onset of symptoms and then some kind of tipping point that really pushes them over the edge and causes them to be evaluated. So history of recent or remote trauma, often at fall, may be characteristic. A history of immunocompromise or IV drug abuse may herald an infection. Use of anticoagulation, especially if that's changed recently, or if they have super therapeutic levels of anticoagulation. Any history of spinal instrumentation, such as surgery or of chiropractic manipulation, and any history of cancer. And this could be a primary CNS cancer, but probably more commonly it would be like a metastatic cancer. So from evaluation perspective, I think this is absolutely crucial. It's important that you think about all the different things, that kind of list of things that could cause cauda equina, and ask patients questions specifically designed to elicit signs or symptoms of this. So this could be pain in their back or legs, weakness, which may be characterized by trouble walking, tripping when falling, difficulty getting from a chair, things like that. Bladder dysfunction, and understand that it's disruption of both the autonomic and the motor fibers, kind of this reflex arc in the bladder that leads to loss of sensation and motor innervation to the bladder. So what happens is that patients with cauda equina syndrome are unable to sense the expansion of the bladder as it distends, which causes overflow incontinence. And they also lose the ability to contract both the detrusor muscle and the sphincter muscles to allow adequate emptying. And so that actually causes urinary retention. So that's why they may have, over time, this mixed retention or picture of retention versus incontinence. But it's really important to understand those symptoms. Same thing, similar thing with bowel dysfunction. Are they having significant constipation, or are they having any kind of incontinence? And again, understanding the history and how they're defining constipation or incontinence is really important as well. They may have change in sensation, particularly in the perineum or on the posterior aspect of the thigh, sexual dysfunction, or signs or symptoms of infection. So make sure that you do a really good neurologic exam on these patients. And again, this includes motor, strength, the presence of other lower motor nerve signs like hypotonia and areflexia, sensation. And important to test both light touch and, although we often shy away from this, pinprick sensation. And that's because patients with Cauda equina syndrome typically have preserved light touch and pressure sensation, but they may lack pinprick sensation. And so, checking that in the posterior thigh and in the buttocks is really important to help differentiate, patients who may have true Cauda equina from patients who have a herniated disc or some other pathology that's not actually causing severe compression. So doing a rectal exam is important, and checking, as well as checking the bulbocavernosus reflex, which may help with that. And again, when you're checking the bulbocavernosus reflex, use it, after a Foley catheter is placed or stimulating the glands. It should stimulate the bladder and cause contraction of the anal sphincter. So that is an involuntary reflex loop. An abnormal response would be loss of involuntary contraction of the anal sphincter. So helpful to understand why and how that works. And the last thing is a urinary examination. So patients who have a lot of urinary retention may have even a palpable or very full bladder. And then important to check a post-void residual. And this is remarkably easy to do. The gold standard is to place a Foley catheter as opposed to using a bladder scan. But essentially, you ask the patient to void and then measure how much urine is left in their bladder. And I say using a catheter to actually drain the bladder is probably better than a bladder scanner, because the sensitivity of bladder scanners is pretty low, unfortunately. So somebody who voids and has full voluntary control of their bladder should have a post-void residual of less than 50 cc's. And some people will say up to 100 cc's. So, but regardless, once you get over 100 cc's left, if you have more than 100 cc's in your bladder after you think that you've emptied it, then that is by definition urinary retention. So that is a sign that is, again, something that you could easily measure in the ER. So imaging, we always start with x-rays and get AP and lateral x-rays of the lumbar spine. And these may show if you have a burst fracture or an infection, for example, destruction of the bones like osteodiscitis, but it won't show any soft tissue pathology, and it won't show any evidence of canal compromise. So again, understand what x-rays are likely to show, but also the limitations of this test. And then an MRI or a CT will show a space-occupying lesion in the spinal canal, and it will also show compression of the neurologic structures. In patients in whom MRI is contraindicated, you can consider getting CT myelography, which is essentially where some contrast dye is injected into the spinal canal, and it gives you what, for all intents and purposes, is a silhouette of any kind of soft tissue mass that is impinging on the canal and the spinal roots. However, the CT myelogram will not have the same granularity as an MRI, which is why it's a little bit, an MRI is preferred if possible. Importantly, regardless of the imaging modality, the imaging should be done expeditiously. So these are the kinds of things that should be seen, whether it's in the clinic or in the ER, and obtained very quickly. So how do we manage this? Well, surgical decompression, so removing the soft tissue mass, removing whatever is impinging on the spinal nerve roots. And so this should be performed emergently as soon as possible. And the specific decompression technique could be a microdiscectomy, which you see on the left, where you remove part of the limb, or you do a unilateral laminectomy and remove part of the facet joint, could be performed. Or you could do a complete laminectomy, which is a broader decompression where the entire lamina is removed. And the determination between one versus the other will depend on what's causing the compression of the spinal nerve roots, or the spinal nerves, whether it's the level of the injury or the type of impingement, and also the extent of the pathology, whether it's one level or multiple levels. In most cases, surgical decompression should be performed as soon as it can safely be done. So surgeons generally agree that we say time is spine when it comes to stopping symptom progression, and data has shown a clear benefit in terms of symptom recovery for decompression performed within 48 hours. But the literature has not shown a definitive benefit to surgery performed within 6 or even 24 hours. So time is spine, but as long as you get to it before 48 hours, then I think that is justifiable. What we know, however, is that decompression greater than 48 hours after symptom onset is associated with worse outcomes when it comes to recovery of sensory symptoms, motor deficit, urinary symptoms, and rectal dysfunction. And unfortunately, patients who present with bladder symptoms often have worse outcomes regardless of surgical timing. So once you have bladder symptoms, then early decompression versus late decompression, unfortunately, that portends a worse outcome overall. You may see, if you've had any exposure to spine surgery, is any instrumentation necessary? So, and the answer to that is most commonly no. So often, especially if you're only doing a single or maybe a 2-level procedure, then instrumentation is not necessary. So you don't necessarily need to fuse the levels after this has been performed. And again, it depends a little bit on the pathology. So what is the soft, or what kind of structure is causing a kind of Cauda equina syndrome to begin with. But importantly, this is not something that necessitates fusion. Any other questions about this? I think the most important thing for Cauda equina is really to be able to correlate the what with the outcome. So, what is the anatomy? What does that mean in terms of symptoms? And how will the patient present with that? And so kind of being able to make that correlation between anatomy, symptoms, and imaging, for example, is really important to understanding Cauda equina syndrome, how it presents, and how we manage it as well. And then just remember, this is, urgent decompression is critical for helping these patients return to function. The last couple minutes and talk about necrotizing soft tissue infections. Some of the attendings were talking on this call or before we got started with the presentation and saying this is one diagnosis or one kind of group of disorders that we really do not want to treat. And that's because this is a very challenging surgical problem to have, and sometimes a very challenging thing to correctly diagnose and manage as well. So let's talk about these. The necrotizing soft tissue infections are a heterogeneous group of life and limb-threatening infections, and they can all involve all soft tissue layers, including skin, subcutaneous tissue, fascia, muscle, even bone. And the most common one that I'm sure you've heard of is necrotizing fasciitis, but it's important to understand that this truly is a spectrum, and that you can have necrotizing infections like pyomyositis and other kind of degrees of soft tissue involvement that are equally severe. Importantly, you must have a very high suspicion of infection for necrotizing soft tissue infections because delayed diagnosis is associated with very high morbidity and mortality, and that can include amputation and death. And sometimes, especially in the early course, it's difficult to distinguish from more benign problems like cellulitis or erysipelas or other soft tissue diagnoses that can be managed primarily medically with antibiotics alone. Risk factors for necrotizing soft tissue infections are things like old age, immunocompromise, and remember that diabetes causes a certain degree of immunocompromise as well. Smoking, a history of MRSA infection, or also a history of group A strep infection or exposure to patients, like patients in the community who have had group A strep. But 40% of patients don't have any known risk factors. And so this may be an otherwise healthy individual who presents with a quite concerning diagnosis or a quite concerning presentation. So there are 4 types of necrotizing soft tissue infections. Type 1 is the polymicrobial type, and this is actually the most common type. It represents about 70% of cases. These disorders are primarily caused by anaerobes, and in general, 2 to 4 microbes are involved. So polymicrobial infection, several microbes will be involved. It tends to affect patients with risk factors such as diabetes. And this type of necrotizing infection tends to have a predilection for the trunk and the perineum. So it's a little bit less common in the extremities, but it is also seen. Type 2 infections are monomicrobial infections, and these are caused by beta hemolytic or group A strep. And this is also known as strep pyogenes. These diseases are due to virulence factors that are secreted by the strep pyogenes, and they can also be confounded by co-infection with Staph aureus. So these patients can get very sick. And interestingly, they're often young, healthy patients. So this is the category of patients who has no known risk factors, but presents with a kind of very rapidly progressive and concerning presentation. And this type of monomicrobial soft tissue infection tends to involve the limbs. Type 3 pathogens are usually Clostridium or gram-negative bacteria, and this can be things like Vibrio species and Aeromonas species. And these infections tend to be associated with crush injuries or with surgical wounds. So these are often GI or GU surgical wounds, and they can involve the limb, the trunk, or the perineum. So really anywhere, most anywhere in the body. And the fourth time are fungal infections. So this could be Candida, it could be zygomycota, and these infections tend to affect immunocompromised patients or immunosuppressed individuals. And they have a predilection for the limbs or the trunk or the perineum. And one thing that's it's kind of still to be determined about necrotizing soft tissue infections is that the common pathway between inoculation and systemic disease seems to be kind of activation of an exaggerated immune response. So you get things like platelet aggravation, you get microvascular occlusion, tissue ischemia, tissue necrosis. But and while the virulence factors in those pathways are better understood for organisms like staph pyogenes, it's not really necessarily understood in detail for all of these other organisms. So again, this is an area where we still have a lot to learn. Most of these patients have a history of very mild or innocuous trauma, but they present with severe and very progressive pain. And sometimes, often at the point where they're getting very sick, then they may actually develop anesthesia in the limb or loss of pain. And that's because the cutaneous nerve endings can actually be obliterated by the pathologic process itself. So patients will develop local erythema and edema, and you'll see these on the picture on the right here. Some patients will present with bulla, which are highly specific for necrotizing soft tissue infections. And you may have crepitance as well. And that's what we often hear about in medical school, but recall that that's really only with anaerobic infections. So patients may also develop or have a rapid progression of clinical symptoms and can present with a SIRS or a sepsis type picture as well. Certain laboratory findings have been identified, and these have been used to form the LRI NEC score. And this stands for Laboratory Risk Indicator for Necrotizing Fasciitis. And this tool is developed to help differentiate neck fasc from cellulitis, abscess, or other relatively more benign soft tissue infections. So the variables that are included are the CRP, white count, hemoglobin, sodium, creatinine, and glucose. So all things that are pretty typically obtained in patients who are undergoing evaluation for infection. So you can have a score as low as 0 and as high as 15. And in general, scores less than 6 are thought to represent patients who have a low risk of neck fasc. And when you use a cutoff of 6 or higher to indicate a higher risk or moderate or high risk for necrotizing fasciitis, then this score presents you with a positive predictive value of 92% and negative predictive value of 96%. I want you guys to note, however, that 10% of patients that means that 10% of patients that have a score less than 6 will still that have a score less than 6 will still have or eventually get a diagnosis of necrotizing fasciitis. So this is something that you have to use very carefully. It should not be used as the one diagnostic tool, independent of other findings like the history and exam, but it may be something that can kind of help support one diagnosis or another. So again, don't use this score to rule out neck fasc in patients who have signs or symptoms of the disease, since the score less than 6 can still be associated with the diagnosis of necrotizing soft tissue infection. And I will say that in my experience, using this score is considered part of a diagnostic algorithm, but certainly, again, should not replace physical exam or history. As both of our moderators alluded, this is a difficult diagnosis to make. So kind of the more information we have, the more helpful we can be. This is one, I think, diagnosis where imaging studies generally are less helpful. And that's because necrotizing soft tissue infections are primarily a clinical diagnosis. And the imaging studies may or may not actually contribute helpful data. X-rays may or may not show subcutaneous air. Again, they might if there's a gas-forming organism like an anaerobe, but they might also be normal. Axial imaging studies like CT or MRI may show things like thickened fascial planes that are suspicious for a fasciitis type picture. They may show air in the soft tissues. They may show deep fluid collection, but a patient who is truly sick or is rapidly decompensating should not, do not delay surgical management in order to go obtain a confirmatory imaging study, because you may not actually get a confirmatory study. So those patients should be brought rapidly to the operating room. So what does treatment look like? Well, treatment of necrotizing soft tissue infections is surgical debridement. It's, surgery is treatment number 1, 2, and 3. Concurrent with surgery, we can give them broad spectrum antibiotics and supportive care. These patients are, always in the ICU. But again, surgical management should not be delayed so that the patient can get a dose or more of antibiotics. What they need is surgical decompression of this infectious process and source control. A critically ill patient in whom you're not sure of the diagnosis and who is not responsive to early aggressive debridement may require amputation. And this is why it's so important that these patients be identified early and probably go to surgery early, like Dr. Lang said, because unfortunately a delay may necessitate amputation for source control. So initiation of broad spectrum antibiotics and supportive care can often be started concurrent with surgical management and then narrowed as cultures return. And most of these patients require repeat surgical debridements, and about half of them will eventually require some kind of soft tissue coverage, like skin grafting or soft tissue transfer, in order to address the soft tissue deficits that they're left with after a complete debridement of the infectious process. Does anybody have any questions about our treatment of necrotizing soft tissue infections or the workup, and or did Dr. Lang and Dr. Pilson have any comments or suggestions to make?
Yeah, these are scary, quick things that happen. I would say when I see air in the soft tissues on radiologic studies, either X-rays or CT scans, it kind of cinches the deal. It's like, okay,
Yeah.
that's an anaerobic infection. You can tell that it's not, and surgical debridement necessary. So when they're positive, they're helpful. But
yeah, the one time I've seen that be a little, us having to parse out a little bit more, is patients who have wounds, especially chronic wounds. The tough thing is that a chronic wound can develop, especially for a polymicrobial or type 1 neck vash, can develop into a necrotizing soft tissue process or soft tissue infection. However, I've seen plenty of patients with a wound and then, perhaps a wound infection who had some air or gas directly adjacent to it that did not represent necrotizing soft tissue infection. And, you as the orthopedic provider will be asked to see the patient and interpret those images because, your ED or general surgery colleague is understandably worried about that. So again, see the patient, examine them, and think thoughtfully about it. But know that that gas in between the fascial planes on either an X-ray or on an axial image like a CT or MRI is definitely pathognomonic for a process like this.